Good evening, everyone. Good evening, dear colleagues, dear ladies and gentlemen. It's a big pleasure for me to welcome you to the URO webinar in collaboration with the ESIU. My name is Bonkat. I'm the chairman of the guideline panel on urogenital infection of urology of the European Association of Urology. Furthermore, I am a member of the section of the ESIU. And first of all, I would like to send my best regards from Basel to everyone. And I hope that you are all, your loved ones and your families are well during this COVID pandemic and that things are going better in the near future. The topic of our webinar today is prostate biopsy and infectious complications. As you know, prostate biopsy is still the gold standard in the diagnosis of prostate cancer. In the last years, many developments have been made to improve this diagnostic approach. Unfortunately, on the other hand, complications are rising as well. And today, we have two experts in the field who will give presentations about this topic. The first speaker will be Dr. Alidjanov. He is a board-certified urologist from the University in Giessen. He is member of the ESIU and he is dealing mainly with the data of the GPIU study, the big study of the ESIU section. And he has published recently a paper and he will give some interesting insights and data. The next talk will be performed by my dear colleague and friend Tommaso Kai from Trento, Italy. It is how to avoid infectious complication after prostate biopsy. He will speak about new insights in the antimicrobial prophylaxis and further means how we can reduce these complications. After the talks, we have time to discuss your questions. We will give answers. And finally, we will have our final remarks and we'll end the webinar in time. So, as always, time is running. I would like to ask Jack to start with his talk, the negative aftermath of prostate biopsy. Jack, good luck.
Well, thank you, Professor Bonkat, for the nice introduction. And good evening, dear ladies and gentlemen. First of all, I would like to express my gratitude and honor for being invited to such a great event. My name is Jahangir Alidjanov, and I am a German researcher born in Tashkent, the capital city of Uzbekistan. And I have no conflicts to be declared. So here you can see the short outline of my current presentation. First, we'll go very fast through the current state of the art. And second, I will introduce you to the results of our recently published paper. Well, in fact, my presentation will be mostly focused on this paper. So at the end of the presentation, you will receive take-home messages as a summary, and you will thereafter be offered acknowledgements and special thanks to our researchers on the screen at the time of questions and answers section. Well, shortly on the history of prostate biopsies and complications. Well, the prostate biopsy was firstly introduced in 1926 in Young's Practice of Urology textbook, which was the magnum opus of the father of modern urology, Hugh Hampton Young. In 1930, the prostate biopsy evolved from the open biopsy into the minimally invasive transperineal, needle punch, and needle aspiration biopsy techniques. The transrectal route was introduced in 1937 by Astardi. And after the introduction of ultrasound in the medicine, Takahashi and Ouchi have reported about the ultrasound-guided transrectal biopsy. But the quality of the imaging on this time was very poor and had no clinical interest. Up to 1974, when Watanabe and co-authors first demonstrated the clinically useful transrectal ultrasound images of the prostate. And naturally, simultaneously with the development of access techniques, biopsy needles also have evolved, becoming less traumatic, more specific, and entering a separate branch of the production of needles designed specifically for the prostate biopsy. And finally, in 1989, Hodge and co-authors presented the targeted biopsy to replace random samples, thus marking the beginning of a modern era of prostate biopsy. Throughout all of these years, the authors analyzed the complications of various biopsy techniques, along with such complications as fistula formation, hematuria, hemospermia. They also reported about the infectious complications such as mild fever, bacterial contamination of urine, prostatitis, bacteremia, septic shock, lethal cases due to this septic shock. And they proposed a different pre and post biopsy antimicrobial regimens to fight against these infectious complications, which were included in the group of hospital-acquired urinary tract infections. Now we jump to another important period that marked the beginning of the international study of hospital-acquired infections, including also the infectious complications after the prostate biopsies, namely in 2003, when the first international multi-center cross-sectional pan-European prevalence study on nosocomially acquired UTIs in urology departments was conducted. Today, this study is called Global Prevalence Study of Infections in Urology and conducted annually in November and December each year. This study has provided us with a deeper understanding of hospital-acquired UTIs and has become the source of wealth of data and corresponding publications. You can find more detailed information about this study on the ESIU website. Well, the study of infectious complications of prostate biopsy branched off from this GPIU study in 2010, becoming, let's say, spin-off study. The ESIU section of infections in urology has analyzed and published the first results of the study in 2013, reporting on the rate of 5.2% of infectious complications after prostate biopsy. Well, in 2011, Loeb and co-authors reported on the results of their study, which included more than 17,000 men who underwent the prostate biopsy and about 135,000 controls in the USA. According to their reports, the rate of infectious complications after the prostate biopsy increased more than twofold within 17 years, as you can see here. In 2013, Loeb and co-authors reported up to 6.3% of the rate of infectious complications after the prostate biopsy among different studies. In their review paper, so Dr. Tommaso Kai and co-authors have proven the increasing rate of infectious complications and proposed to focus on the first selection of patients at higher risk on targeted antimicrobial prophylaxis, well, based on microbiological sampling before biopsy, and to consider alternative antibiotics to fluoroquinolones with improved susceptibility to be used for prophylaxis. Today, you have a great opportunity to hear from him personally, just after my just boring speech. Well, sorry, going back. Well, in one of the most recent review papers, Dr. Adrian Pilets and co-authors have concluded that the antimicrobial prophylaxis before a biopsy is essential, but the duration of the antibiotic prophylaxis is still debatable and needs further review and researches. And the panel of ESIU guidelines also strongly recommend antimicrobial prophylaxis before the transrectal biopsy. Finally, we came to the main part of my presentation, namely to our recently published paper devoted to statistical analysis of the data collected from these prostate biopsy studies between 2010 and 2019. Now you can see on your screens the short information about the study and the data selection for the analysis. It is okay. The study, as I said, performed annually starting from 2010 every year, except in 2015, when the study was not performed due to the update of our online system of the data entry and the whole database. We therefore decided to use this year as a cutoff to allocate the patients to two cohorts. And in distinction from previous publications, we decided to classify symptomatic complications after the biopsy to lower UTI symptoms or LUTIs, such as frequency, urgency, dysuria, and prostate pain, which might be associated with local trauma rather than the infectious complications. And the second group of these symptomatic complications is severe or systemic UTIs, such as loin pain, rigor, and fever, which more probably are associated with the infection. By the way, this strategy was found as a good idea by the majority of peer reviewers of this paper. That's just me bragging, you know. Okay. Well, on this slide, you can see the methodology of the data presentation, statistical analysis, and the software used for this statistical analysis and the graphical representation. It is more a point of interest for those who really hooked on statistics. And if you don't mind, now and further, I won't give a detailed description of each slide, focusing only on the significant points to avoid boredom and to spare your time. If you want to take a closer look at some of the details, you can watch the presentation later on YouTube, pausing the video on particular slides of your interest. On these graphics here, you can see the proportions of cases available for the analysis per year and per cohort. Well, as you can see, well, the number of inputted cases is going down per each year, and that's not good, actually. Therefore, I would like to promote your active participation in future GPIU studies. It's really interesting, guys. Well, these graphs represent the median ages of the patients included in the analysis. As you can see here, there was no statistically significant difference between different years and also between two cohorts. On this slide, you can see how the prescription of antimicrobial prophylaxis has changed over the years. When comparing cohorts, there was a significant increase in prescription of antimicrobial prophylaxis in the later cohort. Well, to be honest, I don't like such stacked bar plots and bar plots in general, but when one presents proportions, one has to admit this type of graphics. They are anyway, yeah, look better than pie charts, aren't they? Well, going further, so these charts represent how the prescription of various combinations of different antimicrobials for the prophylaxis have changed over the time. As you can see, the rate of the prescription of the combinations of antimicrobials has decreased during the years significantly, and in cohorts, as you can see, it was a significant decrease. Well, just a moment. At the top of the charts, you will find the population number labeled with a capital N, and the number of respective cases and proportions are given on the top of each bar. So this red dash dot line on the year 2015 represents our cutoff to cohorts, and this blue line displays the overall trend to decrease or increase. Well, it was calculated using this logistic models, and they represent the dynamics let's say, of the change in years. And the p-values of the comparative analysis are also shown at the top of graphics. Well, as for fluoroquinolones rates as the prophylaxis, they remained relatively stable over the years, excepting the year 2019. This may be due to recent recommendations not to use fluoroquinolones for prophylaxis. However, when comparing two cohorts, you can see that the prescription rates were significantly higher in the later cohorts. The increasing trend of prescription was found for cephalosporins and for aminoglycosides. The duration of antimicrobial prophylaxis remained relatively stable during years of study. But when comparing cohorts, it was noted that the later cohort had shorter time of the duration of the prophylaxis. Maybe it's maybe good, yeah, fighting against the resistance. Well, these bars represent the change in rates of routes of the performed prostate biopsies. And as you can see, the rates of the perineal route, it's green, yeah, have significantly increased with the simultaneous significant decrease in the rates of transrectal biopsy. But the proportion of transrectal biopsies is still enormous higher than rates of the perineal route. Now I am going to briefly inform you about the symptomatic complications following prostate biopsy noted in our studies. As you can see in this diagram, the majority of complications were noted in combination with each another. These graphs are therefore very illustrative in such cases. True that they make it a little more difficult to see the amount of each complication individually, but you can find this information here on the left side of the slide. Well, these plots illustrate the yearly increase of symptomatic complications after the prostate biopsy. Thus, our findings are consistent with the reports of other researchers. And now, when you look at the following slides, you can see that such an increase was more due to lower UTIs, while the rates of SUTIs remained relatively stable. They did not differ between each other in cohorts also. Well, here are very interesting graphs. As you can see, cases after the transrectal biopsy here. Yeah, here is legend. So cases after the transrectal biopsy more probably seem to develop both LUTIs and SUTIs, while among the patients after the perineal biopsy, no case of SUTIs was noted, and also for individual symptoms. But please keep in mind the difference in the number of cases available to be analyzed. We have only 56 cases after the perineal biopsy. Well, this graph represents the risk ratios of symptoms depending on the route of biopsy. It is not the usual case when one uses such force plots for these cases. They are usually used in meta-analysis, but who said that one cannot use them in our case? I personally like these graphs, Here you can see that transrectal biopsy route is more risky for SUTIs, and perineal route of biopsy is strongly associated with LUTIs. Here below, you can see that, and here, the risk factors, risk ratios of each individual symptom. These confidence intervals here, they cross the reference line, meaning that the p-values in these cases are, well, not very significant. But again, it can be a result of a great inequality in the numbers of cases in groups. These graphs represent the proportions of symptomatic cases depending on the antimicrobial prophylaxis. Such complications expectantly noted significantly more in those patients who did not receive antibiotic prophylaxis, as you can see here, these blue bars. And expectedly again, sorry, antimicrobial prophylaxis seems to reduce the risk of almost all of symptomatic complications and notably SUTIs. It seems like the patients receiving combined antibiotic prophylaxis developed symptoms more frequently than those who were receiving prophylaxis with a single antimicrobial agent. Yeah, surprising. Well, fluoroquinolones have shown themselves significantly more effective compared to the average efficacy of all other antimicrobials here. But as I said earlier, again, about proportions, the proportions of patients receiving fluoroquinolones as prophylaxis was enormous high comparing to other antimicrobials. And almost the same for cephalosporins. Well, but aminoglycosides have surprised me really. Can you see here that the patients who were receiving aminoglycosides as a prophylaxis developed symptomatic complications significantly more often than those who received other antimicrobials? It's interesting. Yeah? Well, we also noted that there was no significantly statistically significant difference between symptomatic and asymptomatic cases in regards to the duration of antimicrobial prophylaxis, as well between here patients with SUTIs and LUTIs. The same for individual symptoms, excepting maybe only rigor, but as you remember, there was only a couple of cases with rigor. And finally, we are in the last chapter of such a boring presentation. Here you can see the proportions of patients who sought help within 2 weeks after the prostate biopsy and the types of the medical help which they have received. And again, as it can be seen in the diagram, some patients have received more than one type of the medical service. On this final slide, you can see graphs representing the dependence of the seek for the medical help and its types from the route of biopsy. Notably, that the patients after perineal biopsy sought medical help more often than those who underwent the perineal biopsy. But the difference was not significant. And there was the interesting thing that this medical seeking for the medical help in the patients with after perineal biopsy was limited only to primary care clinician office, and there was no any case of hospitalization after the perineal biopsy. And it can also be seen in the forest plot. Moreover, there were 2 lethal cases due to urosepsis, and both cases were after transrectal biopsy. So these were the last graphs of my presentation, as I promised. Other details are given in our paper. It is published as open access, and I hope that you will find it a bit more interesting than my speech. Well, and while you're reading the take-home messages, I find it necessary to notice that right now we are a bit far from making any strong recommendations based on our data. There are lots pros, but there are a number of cons, some of which are, okay, this inequality of cases in variety of variables. But we actually have found promising risk factors at least, and promising outcomes, which are to be analyzed using more robust and advanced statistical methods, regression models, machine learning techniques, maybe neural networks and support vector machines. Well, we are planning to submit our next paper within this year with the results of such analysis, and we are going to include the study data from year 2020. And your participation in future studies is more than appreciated to support the analysis with valuable data and to help to reduce the symptomatic complications of the prostate biopsies. Thank you in advance for your future participation. And now I think it was my final slide, and I think we can start the questions and answers section.
So, Jake, thank you very much for this very nice presentation. A lot of interesting data. I would like to ask you 2 or 3 questions coming from the audience. So I have one question. Was there a difference in the number of courses taken by transperineal route as transrectal? That might explain the difference in local complications.
Yes, you are right. So there were differences between the number of cores, and interestingly, it's just a basic statistics, okay? I have to say it in advance. So we have found using this just modeling for the prediction of the symptomatic complications using this number of cores as well, using this statistical modeling. And what interesting thing which have found that more number of cores, well, were associated with lower frequency of post-operative post-biopsy symptomatic complications. But again, we have to analyze it more deep using more advanced techniques.
Okay, thank you very much for answering this question. I have already here a lot of very interesting questions, but I must say they will be mainly be answered after the speak of Tommaso K, because of course the audience is interesting how we could avoid now these complications, and therefore I would like to ask Tommaso to give now his speech, Professor Kai, and then we can discuss all these clinical relevant questions thereafter. Okay, so I close my video, and Tommaso, please start your presentation.
Okay, thank you, Gernot. Good evening, ladies and gentlemen. Many thanks to invite me into this very interesting symposium about the infectious complication after prostate biopsy. Many thanks to the ESIU Scientific Committee and to Professor Gernot Bonkat for inviting me to speak about how to avoid infectious complication after prostate biopsy. So this is my disclosure statement, and I would like to start from this picture. Rectal prostate biopsy is a unique urological procedure characterized by a low level of invasiveness, but by a high risk of infectious complication. This is very important to take in. As you all know, the prevalence of infectious complication after prostate biopsy is quite similar, both in USA and Europe, but as clearly demonstrated, as clearly demonstrated by Dr. Alejanov in the recent year, we have observed an higher increasing of infectious complication up to 10% of all procedures. But my first question, my first consideration is what does it mean 10% of infectious complication after prostate biopsy? As you all know, more than 1 million prostate biopsy procedure has been performed each year in the United States in order to diagnose prostate cancer, of course, and thus thousands infectious complication has been diagnosed in year. But 130,000 infectious complication have a high impact of healthcare systems especially in terms of high risk of hospitalization, in terms of long stay, hospitalization, mid-time long stay, and moreover, in terms of increases cost. I think that this is the time to rethink our clinical practice. In this our editorial paper published a few years ago, we focused our attention on the risk assessment for the selecting patient at high risk for infective complication, but also we highlight the need for a accurate microbiological evaluation of the fecal microbiota, the fecal flora, before to perform the prostate biopsy in order to identify and select the resistance to specific antimicrobial agents. But moreover, we need to consider a new alternative drug with enhanced susceptibility, and we had a good pharmacological profile in order to use in everyday clinical practice and in order to decrease the number of infectious complications. Moreover, we discussed the role of transperineal approach instead of transrectal approach in order to decrease the rate of infectious complication. In this presentation, I would like to focus my attention on the risk assessment for selecting patients at high risk of infectious complication, on the role of alternative drug with enhanced susceptibility with a good pharmacological profile in order to use in everyday clinical practice. And finally, I would like to discuss with you the role of biopsy route. So starting for all patients-related risk factor that is able to increase the risk of infectious complication, I would like to stress the need for investigate the previous UTI in the patient, the previous UTI treatment, and the previous use of antibiotics. Because this is a very important aspect to highlight, because as being clearly demonstrated in this study, the previous use of antibiotics, for example, ciprofloxacin, is an important risk factor to have a strain resistant to the same antibiotic. And I would like to stress this aspect. Please ask to your patient if they take antibiotic, every class of antibiotic before the prostate biopsy. Moreover, some authors highlight that the previous use of antibiotic, in particular the previous use of fluoroquinolone, are associated with the higher prevalence of fluoroquinolone resistance strain development and the development of ceftriaxone strains, resist cross-reaction in antibiotic use. Moreover, the same authors highlight the need to accurately evaluate the prevalence of ESBL producing bacteria in your local zone in order to avoid infectious complication. Moving to some alternative drug to use in everyday clinical practice, some authors highlight the role of Phosphomycin trumetamol in prophylaxis of prostate biopsy. Several experiences being published, both retrospective analysis then randomized clinical trial, that has been demonstrated that Phosphomycin trumetamol is not inferior to ciprofloxacin or other fluoroquinolone in the prevention of infectious complication after prostate biopsy. And some authors demonstrated that Phosphomycin is able to reach high concentration in all prostatic tissue zone, demonstrating the good pharmacological profile of Phosphomycin in the use of prophylaxis. In this sense, the recent systematic review and meta-analysis from our EU guideline group on urological infection demonstrated that, of course, the antibiotic prophylaxis is able to reduce infectious complication when compared to no prophylaxis, but this review demonstrated also that Phosphomycin trometamol was an alternative to fluoroquinolone in order to reduce the rate of infectious complication. And Phosphomycin trometamol is a good alternative as well as the augmented antibiotic prophylaxis to be considered in everyday clinical practice. Moving to the role of biopsy route, we have some paper. I would like to show only one paper that has been performed by an Australian group in which they demonstrated that the transperineal approach is associated with a zero prevalence of infectious complication after prostate biopsy. The same authors suggest to use the transperineal approach not only in case of patients with an higher risk of infectious complication, but they suggest to use transperineal approach in all patients candidates to prostate biopsy. Recently, our EU guideline is interesting flowchart to use in everyday clinical practice in case of prostate biopsy indication. Our group suggests firstly to evaluate the feasibility of transperineal approach. If it is feasible, it should be preferred, of course. But if not, the second choice is the transrectal approach with an association with povidone rectal cleansing and antibiotic prophylaxis, of course. Another important aspect to highlight, if you need to use a transrectal biopsy, transrectal approach, you need to consider if you can use fluoroquinolone. If you can use fluoroquinolone in your country, you need to consider some aspect before prescribe antibiotics, prescribe fluoroquinolone. First of all, you need to consider a targeted prophylaxis. You should be performed a rectal swab in order to find and to evaluate the prevalence of fluoroquinolone resistance bacteria, and in order to shift your antibiotic prophylaxis to the other alternative antibiotic, such as fluoroquinolone plus aminoglucoside of fluoroquinolone plus cephalosporin, in other words, augmented prophylaxis, or change directly your approach with other alternative antibiotic. So if you can't use fluoroquinolone in your country, you need to prefer an alternative antibiotic such as Phosphomycin trometamol, cephalosporin, or aminoglucoside. Another option that you can use in everyday clinical practice is to use two or more different classes of antibiotics, such as aminoglucoside plus cephalosporin or other. Moving to the recommendation from our society, we need to consider the role of povidone iodine rectal cleansing in addition to the antimicrobial prophylaxis that has been recommended with a high level of evidence and with a strong grade of recommendation. But don't forget an important aspect. Don't forget that the transperineal approach is the preferred route to reduce prostate biopsy-related infection. And in conclusion, I would like to highlight some aspect to take into account before prescribing antibiotic in all patients candidates to prostate biopsy. Please consider the role of local antimicrobial resistant prevalence. In particular, you need to consider the prevalence of ESBL pathogen or superbugs, multi-drug resistance pathogen. In other words, you need to speak about your microbiology, for the local resistance are frequently different from the country and frequently different in the same country. Moreover, you need to perform an accurate risk factor assessment, and you need to perform and use the rectal cleansing with the povidone iodine in line with our guideline. Moreover, you need to consider an antibiotic with a good pharmacological profile in order to reach higher concentration in the prostate tissue, and you need to consider also all antibiotic with a very good susceptibility profile. But the most important aspect that you need to consider and to adherent to our guideline, because our guideline are the most updated guideline on urological infection. Many thanks for your attention, and I'm happy to answer to your question.
So, Tommaso, thank you very much for this impressive talk and this insight about how you can avoid these complications. There's a question coming again and again, and it's a question about an alternative antibiotic, meaning the Phosphomycin. And may I ask you, could you give some advice how to use the Phosphomycin? Should it be taken the day before, the day of the procedure, the day after, a 1 or a 2-time dosage? Any idea?
So, many thanks, Gernot, for this question. I regularly use Phosphomycin trumetamol in the prophylaxis of transrectal prostate biopsy. So my schedule is 3 grams of Phosphomycin trumetamol 3 hours before the procedure, and another dose, another 3 grams of Phosphomycin trumetamol 24 hours after the procedure. Only 2 doses.
Perfect. A next question I have to see. So we have many questions covered, I think, in your presentation. There's one question. Should flagell be added or not? As far as I know, there are no studies have dealt with the use of flagell, and I see no current or added advantage of adding such antibiotic compound, such flagell. What is your opinion, Tommaso?
Flagell, I don't have some data about it. What is flagell? I would ask to you to answer to the question, or to Jack if you have some experience.
So if I might answer, so from my personal view, I know that flagell was added in some studies to other antibiotics, but that flagell was the only used antibiotic so far is unknown for me, and I see really no advantage, because what you have nicely shown in your presentation, and this is what we have to discuss further in detail, that we already know how we can avoid the prostate or the after prostate biopsy infectious complications, namely with the transperineal approach. And this is what you have to consider. I'm aware that it's more costly, it's more time consuming, you need a special equipment. But we, as a guideline group, our first aim should be how we can avoid these complications to protect our patients. And what should we say if we know, and we know it from a more and more becoming robust set of data, that the transperineal approach will help us to reduce, if not to eliminate nearly, these infections. So it's always a little bit a hard discussion for me, because I would advocate to switch whenever possible to the transperineal approach. I have a question now I would like to ask you both. How to apply the povidone in the rectum? Is it an enema? Is it a swab or just fluid? How should our colleagues do it?
I suggested to use an enema of povidone. Of course, I suggested to use it immediately before the procedure. I use the enema with povidone iodine immediately with the procedure.
Unfortunately, today we have not the author of our studies, our expert in the field, Adrian Pilatz, here on board, because we have discussed a lot, and he's a mastermind behind these prostate biopsy meta-analysis, how to reduce infectious complications. I've spoken with him, and he said, okay, we know that povidone iodine is helping us, but we do not know exactly how it should be administered. So we do not know whether it should be just a swab, do it before, is it an enema or not. So it's a little bit up to your experience and how you can use it. So let's see.
No, they're not. I prefer to not use a swab with povidone iodine, because the swab can create a lesion, rectal lesion, okay. And I avoid to use a swab. Okay. I regularly use enema with the povidone iodine.
Very good point. Thank you. So now it's a question regarding the treatment of a complication. So let us consider that a patient will develop a prostatitis, for example, after a prostate biopsy. And the question is phosphomycin useful to treat a prostatitis?
Yes. We recently published a paper about the role of phosphomycin trumetamol in the treatment of patients affected by difficult to treat prostatitis. I think that the problem is related to the long-term treatment effect, because the trumetamol is a salt that is able to increase the bowel function and create diarrhea in the patient if the phosphomycin trumetamol is being used for a long time. However, we regularly use phosphomycin trumetamol in patients affected by bacterial prostatitis difficult to treat. One dose every day, every 48 hours.
Okay.
For 8 doses.
Yeah.
It could be a good alternative to fluoroquinolone or to aminoglucoside or cephalosporin in prostatitis patients.
Very good. Thank you very much. Now we have another thing. Can you report on studies using the perineal approach without antibiotics? So, Tommaso, you have already one study from Australia. I can say that some colleagues here of me in Switzerland have published a study as well, and I know some studies that are currently going, and I know about some studies that have already been performed because I have seen a few abstracts that will be published in the near future. So it's not a big secret, because it's always the same, that if you go for the transperineal approach, infectious complications are very, very rare, if they will happen at all. So many studies will come and they will show us that the transperineal approach will now have no complication, infectious complication, and now is the add-on coming, and they even do not use antimicrobial prophylaxis at all. So this is meaning we have an approach who will save our patients, and we avoid the further pressure on the bacteria to develop resistance. So it's coming, it's a little bit circulating what we are talking about, because we have many advantages regarding the transperineal approach. What I would like to add as well, if you have a question, if you would like to add an antibiotic, you go for the transperineal approach and you are asked, I'm not quite, I know that there are data that nothing will happen, but I will be sure. I would like to be on the safe side. I would like to take an antibiotic. Then I can cite out of our meta-analysis, again, let's say a few studies have dealt with the problem. They compared different antibiotic, antimicrobial regimes during transperineal approach, but they have used different antibiotics. Some studies have used cephalosporins, some studies have used aminoglycosides, so it's not a real different. And what I can say from now, the data from studies which have not used an antibiotic at all, I think if you go for an antimicrobial prophylaxis with the transperineal approach, it doesn't matter at all what kind of prophylaxis you take. So I would recommend that you go for the antimicrobial prophylaxis with the lowest side effects. All right, so. All right, here's a question about the technique. Do you think transperineal biopsy is feasible under local anesthetic as an office procedure, or should it only be done in theater under general anesthetic? What is your opinion, Jack?
Well, I can say about our database, just about the data, there are some cases of the local anesthesia, and there were cases of spinal anesthesia and general anesthesia, and we did not find any significant differences between these three types of anesthesia in regards to the development of post-biopsy complications. So, yeah, it's feasible. I mean, yeah, why not? So people are doing this.
So, Gernot, I regularly use both the transperineal and transrectal approach. So, in a transperineal approach, I use a periprostatic local anesthesia and a skin anesthesia, local anesthesia. I'm more confident with this type of anesthesia. I think that is very feasible in the office setting to perform a transperineal approach with local anesthesia.
Perfect. This is meaning even more advocating for such an approach because many doctors, colleagues are already doing it, and it's published already. It's feasible in the office. So we should really consider this approach, even to do it in the practice in our own clinics. So why not? So let me see whether I have another good question.
Probably the point is that, especially in Italy, for example, the urologists are more confident with the transrectal approach than the transperineal approach. However, I think that we need to stress the fact that transperineal approach is associated with the zero or about zero prevalence of infectious complication.
I have now a question, we can discuss as well. It's about the role of diclofenac suppository for biopsy. So it's not against the infectious complication, but it might be helpful against the pain. As I can say now, again, just from my point of view, because we are doing now only the transperineal approach, that our patients have not any pain at all. So personally, I see no advantage now to give some additional painkiller if it's not necessary. What about your opinion, Tommaso and Jack?
For me, it's not necessary to use a fancy anti-inflammatory drug for the control the pain, because the patient did not present a lot of pain after the procedure. The local anesthesia is enough.
I have now received a lot of comments, and I have seen that some colleagues, they have posted, just for your all information, that they are regularly doing transperineal biopsies under local anesthesia. Very feasible procedure, very low complication rates. I think this is an important information as well. Now, I would like to see whether I find more. So we have a lot of topics covered. We have a question, it's asking whether there's a difference between the size of the needle, if the needle size is bigger compared to other needles. Is it relevant in developing infectious complications? If I can answer this question myself, so this was investigated by Professor Bielers in Giessen as well in his meta-analysis, so it should not be, or is it not related to any complications?
Yeah.
So
the number of core is related with the infectious complication. Neither the dimension of the gauge, neither the number of cores has been related with infectious complication.
it's again a new question. It's a question, it's technical again. How do you guide the needle by perineal biopsy? I think this is again a question of the technique. If you do it freehand, you can use it freehand. If you're going to use a template, then it's like the Brachy template. So it depends. Personally, we use a template because we are doing Transperineal and we are going with our patient in the theater because we are always performing not only a fusion but a mapping biopsy, and it's a little bit more comfortable. Of course, it can be discussed, but we still have the option in Switzerland to do it this way. Huh?
I'm to use the template.
All right.
So I'm trying to answer with typing to these questions, so that's why I'm a bit.
Now I would say, a last interesting question. Tommaso, you have answered it, I think, in advance a little bit, but we can discuss it. What is your opinion on antibiotic drugs combinations use, e.g. fluoroquinolones plus aminoglycosides, when it can be feasible?
Yeah. Very feasible, of course. In case of patients at high risk of infectious complication, in patients allergic to that have some allergy to phosphomycin trometamol, for example, I regularly use a augmented prophylaxis with fluoroquinolone and aminoglycoside, for example. But it's very important to highlight that this is a prophylaxis, it's not a therapy. Yes. Only one dose of fluoroquinolone, only one dose of aminoglycoside.
Perfect. So, what an interesting evening. I think we could still have a debate for hours, and I would like to thank you all. First of all, I would like to thank you, Tommaso. I would like to thank you, Jack, for your nice presentation. I would like to thank you for the opportunity to work with you. And I hope that we can meet in person soon again. Then I would like to thank the ESIU ladies, namely Wendy. She has given us a great support in organizing all this webinar. And I would like now come to my key messages. So, the rates of symptomatic complications after transrectal prostate biopsy has increased worldwide during the last decade. This is what the GPIU study have clearly shown. Transrectal biopsy is associated with a wider spectrum of post-biopsy complications, including febrile UTI, risk of hospitalization, and even mortality. Antimicrobial prophylaxis reduces the risk of the development of symptomatic complications in the transrectal approach. The transperineal approach should be preferred to reduce prostate biopsy-related infections. And in Europe, we have, or at least in the European Union, we have the problem that the fluoroquinolones are suspended as prophylactic agent. So we need alternative antibiotics or targeted prophylaxis in conjunction with povidone iodine rectal preparations. And this is recommended for the transrectal approach if you have to use it. So I would like to thank you all again for your audience, and I wish you and your families all the best. Thank you very much. Bye-bye.